With that in mind, what I'm now going to do is go into some specific examples and specific cases, first around vascular disorders. And I want to use some case examples to highlight a few key points. So using a case example, a 77-year-old male presents to the emergency department for the sudden onset of weakness and speech difficulties. The patient is awake and alert, but does not answer any questions, only staring at the examiner. His wife, who is with him, states the symptoms started exactly 1 hour ago. On examination, there's weakness of the right lower face and right arm. The right forehead appears to move normally, and eye movements are normal. The patient's blood pressure is 126/82 with a pulse of 65. He is not on any anticoagulant therapy. He has a normal PT and INR. Blood glucose testing is 98. A non-contrast head CT is interpreted as normal. Which of the following treatments would be most appropriate? Tissue plasminogen activator or TPA, intravenous heparin, aspirin, low-dose oral prednisone, or high-dose intravenous methylprednisolone. So I think the most appropriate answer for this question is number A, or TPA, or tissue plasminogen activator. And what are some of the clues that I would look for, and some of the things I would expect you to pick up on the test? First of all, there is a focal nature to symptoms. The patient has weakness of the face and the arm, but also has a cortical finding. Right? The patient's aphasic. The patient can't talk back to you. He's awake, he's alert, but he's not talking back. The patient's aphasic. With a right face and right arm weakness, that indicates a problem in the left hemisphere. Simple things in neurology: right side of the brain controls left side of the body, left side of the brain controls right side of the body, left side of the brain typically includes language centers. Patient's aphasic with right-sided weakness would indicate there's a central nervous system problem that's structural in nature affecting the brain. We also know the specific onset of symptoms. The wife is very clear that it was 1 hour. For this case, we have a focal neurologic deficit, we have a time, TPA is the best indication. Other answer options. Intravenous heparin is no longer recommended for any form of stroke. In the past, many years ago it was. There are no recommendations for IV heparin for any stroke subtype. While aspirin is often appropriate for stroke, and maybe in the future for this patient, in his acute presentation, TPA is the more appropriate treatment. Low-dose prednisone and high-dose intravenous methylprednisolone would not be indicated for stroke. It would be for some other neurologic disorders. As you think about stroke cases, a few key things are time, as being of critical importance. In terms of testing, the initial testing of choice is a CT scan. CT scans in acute strokes should be normal. This is an important point of emphasis. Though the patient has had a stroke and has neurologic deficits, CT scans don't typically show any changes for about 24 hours. So our expectation as a neurologist is when we do that initial screening CT scan, that it is normal. What we are looking for is any evidence of hemorrhage, which would immediately contraindicate TPA and some other interventions. Current practice, many medical centers are also adding CT angiogram at the same time, looking for large vessel occlusions for the potential of clot retrieval. The currently standard of care is CT scan alone, though again, often CT angiogram being added on. An MRI scan is a much better picture of the brain, gives us much more detailed information regarding stroke. However, MRI scans tend to be slow, taking upwards of 45 minutes to complete, if not longer, so it is rare to get an acute MRI scan. For the immediate testing of stroke, CT scan is indicated. In terms of treatment for stroke, this is where time is of the essence. TPA can be given for the first 3 hours. There are some centers that will extend that window, but for testing purposes and for most clinical purposes, the FDA approval for TPA is for use within the first 3 hours. So the onset of symptoms is absolutely essential. In real-world practice, as well as on a test, on the test specifically, they should tell you the onset of symptoms. In the absence of a specific onset, the last time the patient was known to be well was the time the stroke started. So for example, say a patient falls asleep and wakes up the next morning with symptoms. The last time they were known to be normal was when they went to sleep, which would often contraindicate them from TPA. So we want a very clear-cut onset for the stroke. The wife in this case told us it was 1 hour ago. That puts this patient within the 3-hour time window. Depending where you practice, you may hear neurologists or interventionalists mention extending the window. FDA approval is currently only for 3 hours, so for test-taking purposes, they should likely keep you within that 3-hour window. Reasons why you wouldn't give TPA are any patient at risk for bleeding. Hemorrhagic stroke is not an indication for TPA. A patient who is fully anticoagulated would not be an indication for TPA, or a patient who's had a recent procedure in which giving someone a blood thinner could be dangerous would be a contraindication of TPA. Essentially, look for any hemorrhagic risk factors as potential contraindications to TPA. If TPA is contraindicated, most commonly because the patient isn't in the window, simple aspirin is indicated at either 160 or 325 milligrams. Both answers would be correct. There's no definitive statement as to what dose. Following a stroke, once we've exceeded that initial time window, simple aspirin or clopidogrel can be indicated for secondary prevention of stroke going forward. In terms of risk assessment, once we're out of that immediate time window where TPA could be helpful, most stroke management is risk factor reduction. The biggest risk factors for stroke include hypertension, diabetes, hyperlipidemia, sleep apnea, smoking, and heavy alcohol use. Our primary role following a stroke is to manage the stroke risk factors by managing these medical conditions. So treatment of the underlying risk factors is of paramount importance, as well as adding some antiplatelet therapy, either aspirin or clopidogrel, each done as monotherapy for secondary stroke prevention. We also recommend screening for atrial fibrillation. If a patient has had an ischemic stroke and has atrial fibrillation, generally the recommendation will be for anticoagulant therapy. As many of you are aware, there is a CHADS-2 VAS score, which can help guide this decision. Looking at it from the perspective of a neurologist, if a patient's had a stroke and has any risk factor, we recommend anticoagulation. Generally speaking, AFib plus stroke equals anticoagulation. Other key points from this case. The patient has only weakness of the lower face. As you may remember, the forehead gets bilateral innervation. So patients who've had strokes will typically only have lower facial weakness, or an upper motor neuron type of weakness. Individuals with Bell's palsy, which is a lower motor neuron finding, typically have weakness of the upper and lower face. So for most strokes, expect only lower facial weakness. If the entire face is involved, that indicates there's a problem with the seventh nerve, which could be on the basis of a stroke, but more likely is a peripheral nervous system disorder. This patient also has evidence of aphasia. He has significant language problem. He doesn't answer questions. There's a number of ways to define aphasia. I think the most important thing is simply recognizing a patient with a language problem, the inability to understand language or reproduce language, is likely aphasic. There are a few versions of aphasia, including a Broca's aphasia, in which a patient has intact comprehension but non-fluent speech. They understand what you're saying, but they simply can't produce language back to you. Patients with Wernicke's aphasia typically have fluent speech, but typically is not making any sense. They will speak fluently, but it's a word salad where there's no intelligent language that is produced. Patients with a global aphasia will have severely impaired comprehension, repetition, and output. They are completely aphasic. Or patients with a conduction aphasia, where there's disproportionate disruption of repetition. What I think would be reasonable to recognize is simply a patient with anaphasia. So someone who has difficulty with language production or understanding language, simply identifying they're aphasic, recognizing that's a problem with the brain and usually with the left hemisphere.